Assalamu alaikum. Let's focus on the remaining genital infections like gonorrhea, chlamydia, pelvic inflammatory disease, and herpes simplex. Let's start from gonorrhea. In the scenario, they will mention a lower abdominal pain, mucopurulent discharge. They might mention rectal infection, ophthalmic infection in a newborn, or a rash and pain in the large joints. But what is gonorrhea? It is caused by Neisseria gonorrhea and it is a sexually transmitted disease. There is a thick mucopurulent discharge. It can be yellowish or greenish. And if you don't treat gonorrhea infection, it can ascend and cause pelvic inflammatory disease. Other than that, it can spread through hematogenous means and can cause non-inflammatory rash and pain in the large joints. It can affect the areas which are lined by the mucosa, such as the eyes, causing ophthalmic infections, rectum causing rectal infections, and urethra leading to urethral infections. To remember this, you can link the word gonorrhea with Gloria genes. You have ordered their chiller with a thick whipped cream topping, link it with a thick mucopurulent discharge. And if you drink a lot of coffee, you'll definitely get a diarrhea. You can link it to the rectal infection. You'll have to pee more, link it to urethral infection. Diarrhea will also cause you abdominal pain, linked to the lower abdominal pain and pelvic inflammatory disease. And you have to wait so much for your order that you will get the joint pains. And there's so much crowding, rush bahut hoga. So you can link it to the rash. The investigations include culture insensitivity and NAT nucleic acid amplification test. And the treatment includes azithromycin and third generation cephalosporin ceftriaxone. You went to Gloria genes to feel easy, azithromycin. And the Gen Z loves Gloria genes, so you can link the third generation cephalosporin to it. While treating gonorrhea, you also have to treat chlamydia, as both of these coexist most of the times. Let's move to chlamydia. The scenario, treatment, and even investigations are very similar to the gonorrhea. There is a mucopurulent discharge. There might be a postcoital bleeding or intermenstrual bleeding. There is abdominal pain, pain in the joints, and conjunctivitis. But the causative organism here is Chlamydia trachomatis. It is also an STD, but it is the most common cause of sexually transmitted disease in a young female. It can have a foul-smelling yellowish mucopurulent discharge, and the risk factor is multiple sexual partners. Investigations include culture and NAT, and treatment includes a single dose of azithromycin, but you can also use doxycycline too. And simultaneous treatment of the current and the recent sexual partner is also recommended. And you should also treat gonorrhea, as usually these both infections coexist. Let's move to pelvic inflammatory disease. If gonorrhea or chlamydia are left untreated, they both can cause pelvic inflammatory disease, and in the scenario they will mention abnormal discharge. There might be a bleeding either postcoital or intermenstrual. There will be fever, bilateral lower abdominal pain, dysuria, dyspareunia, pelvic pain, tenderness around the uterus, ovaries, tubes, adnexa, and cervical motion tenderness. Out of these two causative organisms, chlamydia causes pelvic inflammatory disease way more than gonorrhea. So I've added the 4 stars with chlamydia and 2 stars with gonorrhea. On examination of this patient, you will find the inflammation of the cervix, and you can palpate an adnexal mass or an abscess. If a patient presents with a bilateral lower abdominal pain, you should always exclude the pregnancy. One thing that you should keep in mind is that there is fever in this condition too, along with so much pain in so many areas. Fever clearly means there is an ongoing infection, so pelvic inflammatory disease. When it comes to investigations, the diagnosis is usually made clinically You will notice a cervical motion tenderness. That means when you will examine the cervix, it will cause a pain when it will move during the examination. And when this infection ascends from the genitals up into the cervix, it can also spread to the bilateral broad ligaments and can cause a tenderness in the adnexa or perihepatitis, and it is known as Fitzhugh-Curtis syndrome. You can also notice the pelvic pain on clinical examination. Other than clinical diagnosis, you should get the CBC done, ESR and CRP, they will be raised, and ultrasound as there might be an abscess or mass. And you should rule out the pregnancy by pregnancy test, and laparoscopy is the definitive investigation. Now let's focus on the complications. The infection will cause inflammation in the cervix, uterus, even tubes and broad ligament of uterus. And when this endometrial inflammation of the uterus heals, then this healing can lead to the subfertility. If the tubes will be affected, it will lead to the decreased motility and wall thinning of the ovarian tubes, which can cause ectopic pregnancy. And as previously discussed, it can also cause Fitzhugh-Curtis syndrome and chronic pelvic pain. I have added this slide from the osmosis. You can check the complications and how Fitzhugh-Curtis syndrome is caused. When it comes to treatment of the pelvic inflammatory disease, give tetracycline, doxycycline, third generation cephalosporin ceftriaxone, erythromycin. The only new drug you have to remember, which was not mentioned previously in gonorrhea or chlamydia, is metronidazole. As there is so much pelvic pain, you have to give analgesics too, and do abscess drainage if there is abscess formation, or do surgery if adhesions are formed. Also consult the patient regarding the screening, investigating and treatment of the sexual partner. Explain the risk of the tubal damage and how you can decrease the risk of subfertility by promptly treating this condition, and the use of barrier contraception. Lastly, let's focus on genital herpes. Genital herpes is caused by herpes simplex virus type 2. This virus usually has two types, type 1 and type 2. Type 1 usually affects the oral mucosa, while the type 2 usually affects the genital mucosa. The type 2 of this virus causes vaginal discharge, painful lesions on the vagina and vulva, and multiple ulcers, along with the dysuria or retention of urine. Genital herpes can also cause neonatal herpes if the mother gets the infection in the third trimester or 6 weeks prior to vaginal birth. Investigations include swab from the ulcer that is formed, or you can check the serum or fluid that comes from the vesicles or lesions that are formed, do PCR for the viral infection and culture of the virus. And treatment includes antiviral drugs. Well known is the acyclovir, and as there is so much pain associated with this condition, so give analgesics too. I have added the slides from the UWord notes and emboss notes. You can take a quick look and give a quick read to the past paper questions. That's all for today.